Now let us move to the most important and frequently asked part, adverse effects and contraindications. This section is extremely important because most complications of NSAIDs can be logically explained by inhibition of prostaglandins. Remember one key principle, prostaglandins are not only mediators of pain and inflammation but also protect various organs. So when NSAIDs inhibit prostaglandins, they remove these protective effects, leading to toxicity. Let us begin with adverse effects, which we will discuss system-wise along with their mechanisms. First, gastrointestinal toxicity. This is the most common and clinically significant adverse effect. Prostaglandins, especially PGE2, protect the gastric mucosa by increasing mucus and bicarbonate secretion and maintaining mucosal blood flow. NSAID inhibit these prostaglandins, making the gastric mucosa vulnerable to acid injury. As a result, patients may develop gastritis, peptic ulcers, gastrointestinal bleeding, and in severe cases, perforation. The risk increases with higher doses, prolonged use, and in elderly patients. Second, renal toxicity. In the kidneys, prostaglandins play a crucial role in maintaining renal blood flow, especially during states of reduced perfusion such as dehydration, heart failure, or shock. NSAID inhibit these prostaglandins, leading to vasoconstriction of afferent arterioles and decreased glomerular filtration rate. This can result in acute kidney injury. Additionally, NSAIDs cause sodium and water retention, leading to edema and hypertension, and may also cause hyperkalemia due to reduced renin and aldosterone activity. Third, cardiovascular effects. Selective SIOX2 inhibitors are particularly associated with increased cardiovascular risk. SIOX2 produces prostacyclin, which is antithrombotic and vasodilatory. When COX2 is inhibited, prostacyclin levels decrease, while thromboxane A2, which promotes platelet aggregation, remains unaffected. This creates a prothrombotic state, increasing the risk of myocardial infarction and stroke. Even non-selective NSAIDs can increase blood pressure and worsen heart failure due to fluid retention. Fourth, hematological effects. NSAIDs, especially aspirin, inhibit platelet aggregation by reducing thromboxane A2. Aspirin irreversibly inhibits platelet COX, leading to prolonged bleeding time. This increases the risk of bleeding, especially in patients with coagulation disorders or those on anticoagulants. Fifth, hypersensitivity reactions. Some patients develop aspirin-induced asthma. This occurs because inhibition of coax shifts arachidonic acid metabolism towards the lipoxygenase pathway, leading to increased leukotriene production, which causes bronchoconstriction. Other reactions include urticaria and angioedema. Sixth, central nervous system effects. These include headache, dizziness, and confusion. Indomethacin is particularly known for causing CNS side effects such as severe headache, depression, and even psychosis. Seventh, hepatic toxicity. Some NSAIDs can cause elevation of liver enzymes and, in rare cases, hepatic toxicity. Diclofenac is particularly associated with liver enzyme elevation. Eighth, effects in pregnancy. NSAIDs can cause premature closure of the ductus arteriosus in the fetus because prostaglandins are required to keep it open. They can also delay labor by reducing prostaglandin-mediated uterine contractions. Ninth, a very important condition, Ray's syndrome. When aspirin is given to children with viral infections, it can cause acute hepatic encephalopathy, which is potentially fatal. Therefore, aspirin is contraindicated in children. 10th, overdose toxicity. Aspirin overdose leads to salicylism, characterized by tinnitus, nausea, vomiting, hyperventilation, and metabolic acidosis. Now let us move to contraindications, which can be easily remembered by understanding where prostaglandins are protective. First, peptic ulcer disease. NSAIDs are contraindicated because they inhibit protective prostaglandins in the gastric mucosa, leading to worsening of ulcers and risk of bleeding. Second, renal failure. NSAIDs are contraindicated because they reduce renal blood flow and can precipitate acute kidney injury. Third, bleeding disorders. NSAIDs, especially aspirin, inhibit platelet aggregation and increase bleeding tendency, so they should be avoided in patients with coagulation disorders. Fourth, pregnancy. Particularly in the third trimester, NSAIDs can cause premature closure of the ductus arteriosus and delay labor, leading to fetal complications. Fifth, children with viral infections. Aspirin should be avoided due to the risk of Ray's syndrome. Sixth, patients with cardiovascular disease. Selective COX2 inhibitors should be avoided due to increased risk of myocardial infarction and stroke. Seventh, patients with bronchial asthma, especially aspirin-sensitive asthma. NSAIDs can trigger bronchospasm due to increased leukotriene production. 8. Patients with severe dehydration or those on ACE inhibitors and diuretics. This combination, known as the triple whammy, significantly increases the risk of acute kidney injury. So, to summarize, all adverse effects and contraindications of NSAIDs can be traced back to inhibition of protective prostaglandins. Understanding this concept allows you to predict toxicity and use these drugs safely. If you remember one principle, remember this. NSAID remove both harmful and protective prostaglandins, and this dual effect explains everything about their pharmacology. Thank you.